We know that the resources are challenging us now to get better value from the money, and we know that patients are expecting that we can get higher quality, and that requires us to change the shape of services. The issue for me is that we are simply not fit for purpose to create the right context in which those things can be done locally, and it's too hard too many times for people to do the right thing. They have to do it despite the system that operates rather than as a result of that. What are we saying to the public about the nature of this change that we know in the room has to be made? In 1945, when the NHS was created, I think there was a great coming together of people. There's a real accord between the political classes, those people leading the health service at the time, and the public. That sense of common purpose that actually created the National Health Service, in my view, is needed now because of the challenges that we face. But we are adrift from the public. We talk about integration, we talk about reconfiguration of services. That doesn't connect to people. I'm going to tell a story now which is about my mum. I lost my mum just before Easter. She had vascular dementia. My dad ran out of road in his ability to look after her just before Christmas. And she went into a care home. Now, she went to a care home because we thought that was a better place than a hospital, and we got fantastic care in that home, absolutely fantastic care. And a week before she died, when she lost the ability to swallow, we were all in the room with her, all my family, and she died with us in a very peaceful, loving environment where we were able to all be there for my mum and each other. Now, if we didn't know the system, and many people don't, and she'd have ended up in hospital, hospitals are not geared up for people like that. They're not geared up for people who have physical conditions and are confused. They're not geared up to support families and relatives. And the thing about my mum's care is that it was just over a third of the cost of what it would have cost to keep her in hospital. So the story about why we don't need to be using hospitals in the same way is not about reconfiguration in abstract sense. It's about the fact that we're not dealing with people in the way that they'd want to be dealt with. We're not getting the right resources to people or helping them navigate our system.
A clinical case is really important, it's necessary, but it's never sufficient in order to make a workable change happen. Of course, people are interested in the benefits in mortality and morbidity for the population. They're not enough. There are other things that have to be in place in order to achieve substantial transformational change in the way services are delivered. The second thing we learn is that people, the NHS and others, have got much better at engaging and discussing honestly and openly the issues and the possibilities. A recurring theme is money. Reconfiguration is never something that's done in isolation. Service change is not done in isolation. The public aren't mugs. They know the health service is paid for out of taxpayers' money, and they know that decisions about what happens in the health service have a financial dimension, and it's best to engage because actually they want to be engaged in those discussions, and people get annoyed when people protest too much that it isn't about money.
I think the other thing is the potential for the 15 academic health science networks across the country to work together across traditional divides between social care and health, between primary care and secondary care, and between mental health and acute health, about meaningful change to patient pathways. And I think there's quite a lot about the way we change stroke care in London, about an evidence base, about clinical leadership, and about picking something that's a real public health priority. But I think the other bit about the A in academic health science centre, as well as doing stuff that is evidence-based, I think we need to have an evaluative rigour, an evaluative discipline about what we do. As well as the clinical science, we've got to do the improvement science. So we've got to measure the process as well as the clinical side. But also we've got to do the health economics. There's no point developing a great new pathway if it's platinum plated and unimplementable. And one of the things that did come out of the London Stroke work was the work the University College did about the health economics. And they showed that leap of faith by commissioners at the beginning to invest money in it comes back after 3 months, and after 10 years there's a huge gain. And one of the interesting things about that gain is quite a lot of that gain's in social care, not in health. And one of the advantages potentially of the networks is we can stop some of this kind of silo behaviour where we hold on to our bit and won't give a bit to another area of the public sector.